going to talk to you about TAVI, so we'll go through this. There'll be a lot of slides, and we'll go through this rather quickly. In relation to this presentation, I don't have anything to disclose. The breakdown of aortic stenosis in the U.S., there are about 360,000 patients with aortic stenosis. Severe AS is diagnosed by echo in about 120,000. 75,000 are symptomatic. An isolated surgical ABR is only about 40,000, with about 20,000 being inoperable, and then the TAVR population being a very small percentage of those patients. So out of this big circle of patients that have aortic stenosis, you can see that there are a small percentage of patients that are candidates or that actually get TAVR, and I think this is echoed in the world. This is a treatise that talks about transcatheter valve therapy, co-authored by the former president of the ACC and the president of the Society of Thoracic Surgery, Michael Mack. It'll be interesting reading for anyone who's interested. But calcific aortic stenosis, we all have seen these types of pictures before, and it's deformed, eccentric, calcified, nodular, and rigid. Therefore, it's a hostile target, difficult to displace, prone to fragmentation and embolization. When you look at these panels and when you consider what we're doing with TAVR, and I think you can see some of the inherent problems with this procedure, that we're putting a round peg into this not so round hole. And so some of the potential complications that occur with the procedure are, I think, inherent in just looking at images of the valves. If you look at what a healthy valve looks like on the left-hand panel when it opens and closes, you can see that the tri-leaflet valve closes very nicely, as opposed to on the right-hand panel where you see this very amorphous-looking valve. And here, just representative of a dysfunctional or a diseased valve on the left, and then a valve that's also diseased and stenotic on the right-hand panel. Aortic stenosis is prevalent in patients over the age of 65. For some reason, more common in men than it is in women. There's a latent period, but as we all know from medical school training, that once patients develop symptoms, then their longevity is abbreviated. Who are candidates for therapy? Basically the patients that are symptomatic, symptoms like heart failure, angina, and syncope are sort of prodromes for premature demise. But patients with severe AS that have valve areas less than 1, a gradient greater than 40, and peak velocities of greater than 4 meters per second are patients that are considered for the TAVR trials. Of note, patients that have bicuspid aortic valves are not included in any of these trials to date. And when we look at the patients that actually get treated, you can see in this representation that the majority of patients don't get aortic valve surgery, and aortic valve replacement only occurs in a very small percentage of those patients. This has been a trend even since the late 1990s up until today. This cartoon is, it's rather humorous, but this is what we noticed when we started doing TAVR. Just by screening a patient or a patient having criteria that you would consider them for TAVR, those patients had a very high attrition even while they were undergoing the screening. So it's a very sick patient population. 5-year survival is actually pretty dismal once they get to the point that you would consider them for TAVR. And when you compare this to some other sort of well-known morbid processes, you can see that severe or inoperable aortic stenosis is a very dismal disease process. And at least 30% of the patients with severe symptomatic AS are untreated. There are a lot of different reasons that happens, but clearly, I think we as physicians are not doing our best as far as getting these patients into the right arena for them to be even considered for therapy. What treatments are available? Medical therapy, believe it or not, medical therapy has improved some, that these patients' quality of life can be improved to some extent. Balloon valvuloplasty is becoming in vogue again. There was a period of time that we weren't performing aortic valvuloplasty because of the very poor long-term results, but with the institution of the TAVR programs, we're performing aortic valvuloplasty on a weekly basis, so there's probably not a week that goes by that I'm not performing aortic valvuloplasty. Percutaneous TAVR, mini AVR, and then the standard AVR. Who are the patients? We try to divide these patients into approximately 6 main groups. Those are the patients that are low risk, moderate risk, high risk, and you have the non-surgical candidates, patients that are debilitated but possible surgical or TAVR candidates, and then patients that undergo palliative care. And I think one of the things that we've learned in our TAVR experience is that you should not and you cannot do every patient. Even though in the beginning you're very zealous and you want to do all the patients, you do these patients a disservice by putting them through TAVR, because TAVR, believe it or not, is a big operation, and it takes a patient that has the stamina to rehab after the procedure. And we've had in-hospital deaths from some of our earlier patients, probably because of poor choosing on our part. And we've had deaths in the recovery period because patients weren't able to rehab. So the key is really to match the patient with the appropriate therapy. So medical therapy, valvuloplasty, or whatever, you can look on the right-hand side and you can see that what the treatment options or the best treatment options are for these patients. Certainly the low-risk patients would get a standard AVR and a CABG if necessary. What is the mini AVR? This is a small incision you can see on the left-hand and right-hand panel. And these are the patients that are low risk, have low body weight, virgin chest, meaning they have not had previous sternotomy or radiation therapy. They have normal coronary arteries, or PCI was done, and they have a normal aorta on CT scan. For the transcatheter aortic valves, there's the transfemoral or transapical approach. These are the valves that are being used sort of worldwide to date. The Edwards valve in about over 80,000 patients, the core valve in greater than 50,000 patients. The transcatheter valves that are being used, the Edwards sapien aortic bioprosthesis, you can see is a bovine pericardial valve. The core valve is a porcine pericardial valve. One is balloon expandable, the other is self-expanding. As far as the PARTNER trial or the Edwards valves are concerned, these are the ones that have been used in the PARTNER 1 trial. And now we have a newer generation, and as the technology improves, one of the things that we see is that we have valves that conform better to that non-circular aortic annulus that I talked to you about earlier, and we also have lower profile devices. And so we've gone from 28 French to 25 to 22 French down to 18 French. The schematic of transfemoral aortic valve replacement is basically a balloon inflation over a wire. The valve is positioned in the aortic position, inflated, and then left. I'm going to skip this animation for purpose of time. This is the transfemoral percutaneous access. Looks like a bloody mess, but I put this slide in particularly because this is what we do at my institution. We do not use cut downs. We do all of these procedures percutaneously. And what's important to look at on this slide is that you see that with this transfemoral access, on the right-hand side is where the transfemoral access or the sheaths for the procedure are, and then on the left, we have the patient on bypass. So one of the things that we've learned is that these very sick patients don't rebound once you rapidly pace them or insult them by doing valvuloplasty or implanting the valve, and so they will not recover. They don't rally. They'll either fibrillate, go into cardiogenic shock, and die, whether you put a balloon pump in afterwards or not. And so for those very sick patients that we're performing the procedure on, we will put them on bypass, before we do the valvuloplasty or the valve implant. That's one of the things, again, that we've learned that's helped us to do some of the higher risk patients and have a favorable outcome. As far as the transapical access is performed, it takes a lot of people, and you can look here on the right-hand side. You see in a typical transapical case, we'll have 3 anesthesiologists, a couple of circulators, 2 cath techs or more, a cath lab nurse, 2 surgeons, 2 cardiologists, a couple of fellows and perfusionists. And believe me or not, this is an abbreviated list. There are actually more people than this in the cath lab when we're doing these procedures. So how do we pick which treatment for which patient? And again, it's what I talked to you about earlier, sort of selecting the patient and coupling that patient with the treatment options. but also has to do with the patient's expectations and wishes. And we have a long, candid conversation with these patients and their families before they undergo the screening or the procedure. It depends on the severity of their aortic stenosis, their comorbidities, and frailty. And so patients that are very frail or too frail to rally after the procedure are excluded. This is the Partner 1 design. I think all of you are familiar with this. There was a cohort of patients that were inoperable and a cohort of patients that were high risk that were randomized to either transfemoral or transapical approach. Who are the high-risk patients? Those are the octogenarians, the ones that STS score is calculated to be over 8, and the ones that require close surgical consultation beforehand. This is just a couple of patients from our institution that were in the cohort A. But in Partner 1, what we saw with the TAVR versus AVR, the all-cause mortality at 1 year was similar with both groups. And in the Partner 1 publications in the New England Journal, you can go back and read these for yourself, but I think these demonstrated that even out to 3 years, that TAVR and the AVR were very similar. All-cause mortality with an intention to treat design, you can see, again, out to 36 months are similar. And you're looking at New York Heart Association class, we see that there was a non-significant change between the TAVR and the AVR. The patients that had the procedures done that were either valve replacement surgically or by TAVR did have an improvement in their functional class. Moderate risk patients are sort of a little bit of an enigma because these are patients that could be randomized in the TAVR versus surgical arm of it. But if they're really moderate risk and they don't fit into Partner, these patients get medical therapy or they get a standard AVR or mini AVR. Moderate risk patients cannot receive TAVR unless they're in a randomized trial in the U.S. to date. And who are the inoperable patients? Is basically patients, you can see a lot of the comorbidities, patients that have had surgery, radiation, patients that have porcelain aorta, end-stage renal disease, any of these things that make them exceptionally high risk. And this has to be adjudicated by 2 surgeons, so 2 surgeons have to agree that these patients are inoperable. This is an inoperable patient. This patient had radiation therapy for Hodgkin's lymphoma as a child, and you can see the pretty obvious chest deformity. In addition to that, he's had previous surgery, and on top of it, he has radiation-induced vasculopathy, and you can see the outline of the entire aorta, so you can imagine what this would be like trying to cross-clamp this aorta or even to open this chest and expect it to heal. Non-operable patient evaluation, again, it takes 2 surgeons to decide whether or not this patient is non-operable. What are the options for these patients? If the iliac arteries are large enough, then they may be able to undergo the FDA-approved SAPIEN trial. If not, then the only options for these patients really is to treat them with valvuloplasty and hope or wait for the next generation of devices. This is sort of a representative to just show you what happens or how these patients are worked up. This is a typical presentation that's presented in a conference call. We have a right and left heart cath. We have coronary angiography if they required intervention or revascularization that's been performed before they get presented. And then we have a CT scan that shows not only the angulation of the aortic valve, shows calcification in the aorta, the tortuosity in the aorta, and then a very detailed CT scan that shows calcification in the iliac arteries. And a lot of attention has been made today about the iliac arteries and putting these large bore devices. And clearly these patients that have focal calcification versus the ones that have this crescent-shaped calcification are at significant risk by placing these large devices. We will actually exclude a patient based on the calcification that we see in their on their CT scan. And in fact, when looking at this, sort of early on and trying to sort of push the envelope, we were able to successfully rupture iliac arteries. And unless you've done that or have had the opportunity to do that and don't or have the equipment in the laboratory to treat it, then it's a fire drill. They get very sick in a hurry. By the time you would call for the surgeons, the patient would be dead. And so you need to know how to occlude the aorta, occlude the iliac, deploy covered grafts or stent grafts. Then this is the rest of the pulmonary function test, results of the echo, and then a summary. Here's a patient that has a high STS score, so he goes into the partner 2 cohort being the non-operable patients. And we decide, or based on the CT scan and the echo, what size valve to be used. This movie, fortunately, is playing. This is an aortogram. You can see the TEE probe and the transvenous pacemaker in position. Valvuloplasty is performed with rapid ventricular pacing. This is something we didn't do routinely in the past, but I think if you're doing aortic valvuloplasty, you should use rapid ventricular pacing to do your valvuloplasty. And then similarly with the rapid ventricular pacing, the valve is positioned. And once we are comfortable or like the position of the valve, where we've trapped all 3 leaflets, the valve is inflated, then the balloon is deflated, and it's done. One of the things that we do is we look at the femoral arteries and the iliac arteries, because if there's a complication, we take care of that ourselves in the cath lab before we take the patient off the table. Looking at TAVR, and I think this is important to see that when you look at survival probability, look how these lines really drop off. So this is a pretty sick population of patients, and it doesn't take a whole lot of time to, for these patients to have the nutrition. The partner 2 trial design is demonstrated here, and again, there's an inoperable and a moderate risk, cohort. The patients that have severe aortic stenosis that are inoperable, you can see they're randomized to both the SAPIEN XT and the SAPIEN valve. So this is the smaller device compared to the older device that we use in the partner 1 trial. And you can just sort of follow here. So patients are fairly equally randomized to either device. All-cause mortality in partner 2, again, very similar. With the SAPIEN and the lower XT device, I think the key points are that the vascular complications were lower with the smaller device. The need for a balloon pump in the patients with the smaller device was also smaller or less. So there were improved procedural outcomes, similar 30-day mortality, reduced vascular complications, as I mentioned earlier. Examples of patients that aren't candidates for partner, patients on hemodialysis, patients with small iliac arteries, as I mentioned earlier, patients with prior valve surgery, and Bennett patients. When we talk about recommendations, CMS has come up with a very long laundry list of recommendations for performing TAVR. These are institution-specific, these are hospital operator-specific, and so there's a very long list of things that you have to have as prerequisites before you can perform these procedures. What are the treatment options available? As we mentioned earlier, the AVR and mini AVR, if they're partner candidates, they can be put in one of the trials. The commercial valve is available for some inoperable patients that are high risk. The continued access registries, a partner, are available. And then valvuloplasty as a bridge to transfemoral, transapical, or surgical AVR, as a bridge to AVR or mini AVR, and as palliation for patients that aren't candidates for either one of those therapies. What does the future hold? FDA approval for the XT device. Medtronic trial is near completion. See what's happening in Europe. Both the valves are available. Medtronic tends to be the one that's predominantly used. And if small iliacs, then the transaortic or transapical approach. Selection of therapy is no longer a simple matter. Multiple options for these patients. Optimal therapy for each patient depends upon the expectations. Close collaboration is necessary, and the most common mistake made by cardiologists and internists is not referring these patients. This was an ad from Cedars-Sinai, and I think it sort of sums up everything. A life-saving heart procedure performed without ever opening your chest. Thank you very much.